Morbid obesity, you know very well, is a complex disease which involves an excessive amount of body fat. And it's not just a cosmetic concern, but there are many other risks that are associated with it, like there is heart disease, there's diabetes, there's hypertension, and many other disorders. And all these make anesthesia a challenging one. And to deal with these challenges, we have some eminent speakers who will be dealing on various topics of the morbid obesity. And with me to share the stage as a moderator is Dr. Aparna Sinha. She is fellow of the Indian College of Anesthesiologists, and she is director of anesthesia at Max Institute of Laparoscopic Endoscopy and Bariatric Surgery, Max Super Specialty Hospital, Saket, New Delhi. Her areas of interest are anesthesia and sleep medicine, anesthesia for obese patients, and airway management. And her achievements, which are many, she has listed very few. She is a pioneer in formulating guidelines for anesthesia for patients with morbid obesity. She has written a book on anesthesia for patients with morbid obesity, and she has several publications and lots of presentations all over the country, on the topic of her choice. And she is also running a fellowship program in this particular specialty. Welcome, Dr. Aparna Sinha. The floor is to you. Please proceed ahead with the rest of the program. Thank you very much.
Good evening, everybody, and thank you, Dr. Baljit, for declaring the session open and introducing the topic. So at the outset, I bring regards to all the senior faculty, Dr. Radhakrishnan, Dr. Kumra, and all other faculty members of ICA academics. We are immensely grateful to Dr. Radhakrishnan and all the other members of ICA academics to have included this very vital topic in their series of webinars. So anesthetizing an obese patient is definitely a very challenging task, and it is a topic of increasing importance all over the world. And it is important not just for anesthetizing a patient for bariatric surgery, but we all are aware that we are encountering morbidly obese patients even for non-bariatric surgery. So it becomes very important that we are aware and we can sort of excel, and we sort of go into the details of what are the challenges that a morbidly obese patient might bring to the anesthesiologist. So today's theme is anesthetic considerations in patient with morbid obesity. So this is a very vast topic, and we can go on for days and still we may not be able to touch all aspects of this complex aspect of anesthesia. So however, at the outset in this webinar, we have tried to cover up some basics first. So we have a panel of very distinguished and experienced speakers who have a focused interest in this area. So at the end of the webinar, the participants, mostly the postgraduates, will be able to identify the high-risk obese, learn the essentials of preoperative preparation and optimization. They would know the key areas of anesthetic management, various options for safe pain management, and the post-anesthesia care for the morbidly obese. So with that, I will invite the first speaker, Dr. Dinesh Punhani. Dr. Dinesh Punhani is a co-faculty and a senior faculty at Max Institute of Laparoscopy, Endoscopy, and Bariatric Surgery, with extensive experience and special interest in anesthetizing the obese patients. So without delay, let us start with Dr. Dinesh Punhani.
Good evening. I am Dr. Dinesh Punhani from Max Institute of Laparoscopy, Endoscopy, and Bariatric Surgery Center. Nowadays, we are facing a major pandemic. Because of this, we have forgotten another major health problem, that is obesity. In recent years, the prevalence of obesity has increased globally, and it has become the most common metabolic disease in the world. So today I'm going to speak about physiological changes in obesity. Now, what does obesity mean? In simple language, if you see, obesity is excess weight gain with a negative impact on the health. The word obesity is derived from a Latin word meaning fattened by eating. Nowadays, we find a lot of patients coming to the hospital for various kinds of treatments or procedures. So we must know what type of challenges we face while dealing with such patients. We must know what changes obesity brings to our body physiologically, anatomically, pharmacologically. Nowadays, many obese patients coming to the hospital for weight loss surgery, that is bariatric surgery. So what does bariatric mean? The bariatric is a Greek word. Baros means weight and iatric means treatment. Now the next question is, how do we measure the obesity? So there are various parameters to measure the obesity. The body mass index, waist circumference, waist hip ratio, arm circumference, sagittal abdominal diameter, and so on and so forth. But the most commonly used parameter is BMI, the body mass index, which is weight in kg divided by height in meters square. Why this is the most commonly used parameter? Because most of the hospital actually, they measure height and the weight of the patient. So it is easily retrievable data. It is simple to calculate. But the problem is it does not take into account our body composition. So even muscular patients will show high BMI. It does not tell about the distribution of fat, whether it is central obesity or peripheral obesity. Now, how do we classify obesity? As per WHO, obesity is classified in class 1, the BMI 30 to 34.9, class 2, 35 to 39.9, and class 3, more than 40. Now, these cutoffs are even lower as per MOSE guidelines in Asian patients. There are other several modifications mentioned in the literature about the classification, like morbid obese more than 35 with comorbidities or more than 40 without comorbidities. Super obese more than 50, super obese more than 55. One of the problems we face while anesthetizing morbidly obese is how to calculate the drug dosages in these patients. We all administer anesthesia drug as per total body weight in non-obese patients. But obesity affects the pharmacokinetics and pharmacodynamics of the drugs. The pathophysiological changes in obesity affects the drug distribution and elimination. So giving the drugs as per total body weight might be risky. Plus, these patients have so many comorbidities. Their kidney function might be deranged, they are diabetic, they are hypertensive. So we have to be, their dose needs to be titrated very tightly or very carefully. Some drugs needs to be given as ideal body weight, some as lean body weight, some as total body weight. So you can follow these formulas to calculate the drug dosage. So it is better to keep this kind of a table handy in your operation theater or in your working place, so that you can know which drug is to be given by which what weight, lean body weight, total body weight, adjusted body weight. Obesity is a multi-system pro-inflammatory disorder. The adipocyte not only store the fat, but also secretes biologically active hormone known as adipokines and cytokines. These cytokines, they are inflammatory. pro-inflammatory. And these adipokines, they are anti-inflammatory and they are protective. So the imbalance between these hormones, adipokines and cytokines, leads to adverse effect of obesity. Obesity practically affects all the systems of the body, but its most significant effect is on the respiratory and cardiovascular system. Obesity brings about anatomical changes in face, neck, lungs, chest wall, and abdomen because of accumulation of fat, which can affect the physiology of respiration. Excess fat inside and outside the neck region can make mask ventilation difficult. Now, in non-obese patient, the shape of our airway is elliptical in lateral direction, while in obese patient, it is elliptical in anterior-posterior direction because of the accumulation of fat in the lateral wall of the pharynx, inside and outside. So this can lead to increased airway resistance, which can lead to obstructive sleep apnea, OSA, and in severe cases, OHS, obesity hypoventilation syndrome, which will be discussed in another lecture. I'm not going into the details of this. Now, what happens in normal respiration? During inspiration, the diaphragm contracts and push the abdominal contents downward and forward. At the same time, intercostal muscles push the rib upward and forward. Now, because of the accumulation of fat on the chest wall and intra-abdominally on the viscera, this dynamic of respiration changes. So, obesity basically is a kind of restrictive disease. So, there is a reduction in expiratory reserve volume and FRC, functional residual capacity, and expiratory reserve volume. Even a modest increase in BMI leads to decrease in expiratory reserve volume and FRC. Marked reduction in ERV, as happens in morbid obesity, leads to closure of small airway in dependent zones of the lung, leading to VQ mismatch and hypoxemia and hypercapnia. Here in this table, you can see the most affected is functional residual capacity and expiratory reserve volume. Though other lung volumes are not affected in simple obesity, but these can also be affected in severe obesity. And these changes are more pronounced during sleep, in supine position and Trendelenburg position, and under anesthesia. So if you see obesity, because of its mechanical effect and because of its biochemical effect, can lead to upper airway obstruction and can cause acute hypercapnia during sleep, and it can lead to chronic hypercapnia, which can cause obesity hypoventilation syndrome. So to summarize the respiratory effect, there is a reduced respiratory compliance due to effect on the chest wall, FRC and ERV decreases, VQ mismatch causing hypoxemia, although total lung capacity and diffusion capacity may be normal. But in severe obesity, this can also be affected. And when hypercapnia starts, it is a bad sign. So the clinical relevance of these changes are that these patients desaturate very fast during the induction. They have a very low safe apnea time. So this should be kept in mind while inducing such kind of patient. They should be well pre-oxygenated. They should be managed. Although this will be discussed in the other lecture. So the obesity produces an increase in blood volume and cardiac output because of the increased metabolic demand caused by the excess fat. Now, though conventionally, it is thought that the ventricular hypertrophy and failure is because of the increased cardiac workload caused by the increased metabolic demand. But in recent studies, it is being suggested to be because of exposure to the increased level of leptin and insulin also. Now, another contributor to the ventricular remodeling and progression of hypertension is the increased aldosterone, which causes left ventricular fibrosis and ultimately can cause ventricular hypertrophy and failure. Now, the increased incidence of hypertension in obese is partly because of the volume overload and partly because of the hormones released by the adipocytes, like in ANP, increased angiotensin, and insulin. So the combined effect of obesity on respiratory and cardiovascular system is cardiac failure ultimately. So you can see in this flow diagram how the respiratory effect on the changes in the respiratory system and circulatory system can lead to failure. So whenever we see an obese patient coming to you, they must be evaluated thoroughly, and you must rule out cardiac failure in such patients. Now, obesity is a chronic pro-inflammatory disease. As I told you earlier, adipocytes release biologically active substance, which leads to changes in the circulating coagulation factor. There is an increased fibrinogen factor 7, 8, and plasminogen activator inhibitor. There is a decreased fibrinolytic and antithrombin 3 activity. Plus, the hypoxemia caused by the changes in the respiratory and cardiovascular system leading to polycythemia makes them prone for coagulation. Plus, the mechanical factor like decreased mobility, venous stasis due to the raised intra-abdominal pressure makes them prone for venous thromboembolism. So, thromboprophylaxis in whatever form, mechanical, chemical, or both, is a must in these patients. For the effect on GI system. Obesity is a well-known risk factor for GERD. Abdominal visceral obesity, rather than the BMI, appears more closely associated with reflux esophagitis. Both mechanical as well as humoral factors are responsible for GERD in obese patients. In obese, there is a lower esophageal sphincter abnormality, increased incidence of hiatus hernia, increased intragastric pressure, because of which they are prone for GERD. Now, obesity is the most important risk factor for non-alcoholic fatty liver disease, colon cancer, gallbladder disease. I would like to mention about the metabolic syndrome. Now, this syndrome is commonly associated with obesity. It comprises of hyperglycemia because of the insulin resistance, hypertension, and dyslipidemia. The metabolic syndrome increases the person's risk for heart disease and stroke. Because of their sheer weight, their major joints are affected. So there is an increased osteoarthritis in knee joints, hip joint. They have reduced muscle strength. They have a lot of back problem. So because of this, plus whatever changes we learn in cardiorespiratory system, they have very limited work capacity, poor of effort tolerance. So the conventional exercise testing for knowing the cardiac function in these patients may not be possible because of their joint dysfunction and mobility limitations. Even low vitamin stress testing may not be possible because of the poor acoustic window. So obesity is not a cosmetic deformity. It is associated with so many comorbidities like hypertension, diabetes, ventricular failure, so many. So it is a syndrome. It is a multi-system disorder. Understanding these pathophysiological changes give us valuable information about the challenges we face while dealing with these patients and help us in optimizing planning and management, which is mainly centered around cardiorespiratory system. Thank you.
Thank you so much, Dr. Dinesh Punhani, for an excellent talk. I think you have laid a very strong foundation for the rest of the lectures to follow. Once the pathophysiology of the whole syndrome is clear, I think it's very easy to understand, the anesthesia challenges and various other factors. We'll have a question and answer session at the end of all the presentations. And now I have tremendous pleasure to invite Dr. Aparna Sinha herself to speak on the preoperative preparation of a patient with morbid obesity. Dr. Aparna Sinha, please.
So after learning how the physiology of a patient with morbid obesity is very different from a person who's non-obese, and how it can be so challenging. Now let us see what further can be done. Now I decide to give anesthesia to a patient who has morbid obesity. So how do I prepare the patient? Let us see. So at the outset, I bring greetings from Max Institute of Laparoscopy, Endoscopy and Bariatric Surgery. I have no disclosures to make and no conflicts of interest whatsoever. This lecture is based on current evidence and my personal experience. Anesthetic considerations in patients with morbid obesity. What an anesthesiologist should know. So we are now going to talk about the preoperative assessment and how an obese patient needs to be prepared for anesthesia. So what are we going to learn in this lesson? What are the anesthetic challenges in patients with morbid obesity? How to make the anesthesia safer for this vulnerable group of patients? Which patients are at risk? How do we select the patients? Which is the best form of anesthesia? And what is the journey of an obese after surgery? So let us first look at this NSQIP data set. NSQIP is National Surgical Quality Improvement Program, which was carried out by American College of Surgeons, where they assessed more than 11,000 patients from different countries. So it was a multi-center study, and they analyzed more than 11,000 patients with morbid obesity. And what did they found? They found that patients, they defined the adverse outcomes. They defined adverse outcomes as any outcome where the patient needs to be on ventilator for more than 48 hours. Patient needs to be re-intubated. Patient may go into renal insufficiency, or patient may develop complications like rhabdomyolysis, myocardial infarction, may require more than 4 units of blood transfusion, may return to the OT, or may develop venous thromboembolism. So these were defined as adverse outcomes in any patient, in any obese patient who undergoes surgery. So which were the patients who are more prone? Are all obese patients more prone to adverse outcomes? No, it is not like that. Patients who have dependent physical status, patients who have recent MI, patients who are suffering from angina, bleeding disorder, hypertension, or are at extremes of BMI. Now, these are the patients who are more likely to develop these adverse outcomes. So it is extremely important to identify these patients prior to selecting them or prior to giving them clearance for anesthesia. So we must make note of these conditions. Now let us look at another evidence. Now there is this article that was published in New England Journal of Medicine in 2016. Here what they did was they analyzed patients with high BMI. They followed more than 2.3 million adolescents into cardiovascular death in adulthood, and they found that those adults who were obese right from their adolescence were more prone to cardiovascular events, which means that when we are assessing a patient with obesity, we should also look at how what are the number of years the patient has been obese. So temporal relationship between obesity and disease risk is very, very important. So while we are taking history, we must make note of pound years. So pound years is the number of years the patient in his or her lifetime has remained obese. So it is very important to carefully select the patients and to aggressively preoperatively optimize them. So the aim of pre-op assessment should be, number one, to increase the functional reserve of the patient, to perform the routine and the standard anesthesia assessment, to assess the oxygen reserves, assess cardiopulmonary reserve, to gauge the difficulty of airway, look at all possible comorbidities, find out the concurrent medications, and find out which of these comorbidities needs to be optimized, and to identify those patients who would need periodic assessment. So what is preoperative optimization and how do we identify patients for optimization? Now there is a concept called as the prehabilitation. Now prehabilitation involves preparing a patient for the stress of major surgery by initiating the recovery process even before the surgery and hence enhancing their preoperative functional capacity. We just learned that patients who have poor functional capacity are the ones who do not do well. So it is very, very important that we enhance their preoperative functional capacity. So when we identify patients who are not very mobile, are having severe osteoarthritis, are because of poor cardiorespiratory reserve, hardly having any mobility, and they are more restricted, they are sedentary and more restricted in their physical activity. They are the patients who actually need to be subjected to enhancement of preoperative functional capacity. So they need to be subjected, they need to be red flagged. So they need to be subjected to aerobic exercises, resistance training, optimizing their nutrition. They need to be encouraged for cessation of alcohol and smoking, because all these would actually enhance their ability to undergo the stress of surgery and anesthesia. So aerobic exercises and resistance training does not mean that they have to go to gym. Even while they're sitting, we can encourage them to perform some passive exercises and to do some sort of a weight bearing, do some leg exercises so that there's improvement in their muscle strength. Then it actually improves their endurance and their capacity to deal with the stress of surgery and anesthesia. Now, during the preoperative visit, we must develop a rapport with the patient. When the patient is visiting us, patient might need to come to us for several times. So we must familiarize these patients about what is the course of these patients in the hospital likely to be. What is the preoperative stay like? How will their respiratory reserve and other investigations be performed before they are admitted for surgery? What will happen to them after they undergo surgery? What is the post-operative environment like? Because a well-informed patient will definitely do better. It will not only lead to lesser anxiety, greater patient compliance, but also improvement in recovery parameters. Now, what are the anesthesiologist's main concerns? Now, there are a lot of issues that are brought to our notice when we go through the laboratory investigations. These are obvious issues, but a good anesthesiologist, an anesthesiologist who is actually wanting to anesthetize a patient with morbid obesity will have to actually unravel the hidden issues. So what are these hidden issues? The hidden issues start right from general physical examination. Now, for example, simple things which are very, very basic, like auscultation, may not reveal many things because the sounds may be very muffled. So we must examine the patient in a quiet environment, and we must pick up our findings and correlate them with the investigations, which we would do in other patients definitely also. But in these patients, we have to actually reach out. We have to go out of the way to find out what is happening inside them, because the sounds may not be very obvious. The finding of auscultation may not be very obvious. So we need a quiet environment. We might need to stand behind the patient especially in a female patient, to be able to find out how, for example, what is the breath sounds at the basis, because most of them, 99% of them would have some degree of restriction in this sound. So they definitely may not be having very good air entry in the bases. So we need to identify that, and we need to work on it, and most importantly, document what our finding is. Now, a patient might be having cardiac issues. She might be in failure, but because of deposition of fat all around the neck, we may not be able to see the jugular venous pulse. So how do we find out that the patient is having poor cardiac reserve or a patient is in failure? Any patient with morbid obesity, they might be so much restricted to the bed that they are actually experiencing what is known as physical deconditioning, which means that even the slightest of movement may make them breathless. That does not mean that the patient is in failure. So we need to make a very careful observation and documentation of all that we observe. Now, what about hypertension? Now, patient may not be aware that the patient is hypertensive. One, because patient has never visited the hospital. Second, that during any visit of the patient to a medical facility, we cannot be sure of how the blood pressure was taken, whether the blood pressure was taken using the right size cuff. Now, majority of Asian population would be having conical arms. Now, of course, in some parts of the world, conical blood pressure cuffs are also available. But currently, I don't think they are available in our country. So make a choice. Sometimes using a smaller cuff on the forearm will also give us, there is enough evidence to show that if we use a smaller cuff on the forearm, and if it is well fitting, it will give us the accurate blood pressure. So we must know how we are performing the general physical examination. Now, preoperative cardiac assessment is very, very important for assessing the cardiac reserve. Now, the American College of Cardiology and, they tell us that you need to subject a patient to stress testing before identifying whether the patient, what is the cardiopulmonary reserve of the patient. Now, stress testing may not be possible in a morbidly obese patient because tests like treadmill cannot be accommodate a patient who's heavier than, let us say, 150 kgs. So we should be very careful about what is the modality of stress testing that we are using. So we might encourage them to undergo dobutamine stress echo. But if a patient is having a very heavy chest, very heavy breasts, then the echo findings may not be accurate. So we need to identify patients who would be undergoing dobutamine stress echo, or sometimes for them, transesophageal echo might be a better idea. And in centers where these facilities are not available, even simple tests like an electrocardiogram or chest X-ray give us very vital information. And we must look for, signs of right ventricular hypertrophy in an ECG, signs of right ventricular systolic pressure in echo. Chest X-ray may be showing cardiac enlargement, abnormal pulmonary vasculature, which may be suggestive of cardiac failure. So even if we do not have advanced tests available in our center, the simple tests we must know how to interpret. And they are also very, very informative. Now let us look at another study that was published in 2013, and there are many more studies which have similar results. Now they found out that the poor postoperative outcomes are closely related to patients who have sleep disordered breathing, especially obstructive sleep apnea. So they found that every adverse event, be it cardiac, be it respiratory, be it an unplanned requirement for a non-invasive ventilation or a re-intubation, is more common in patients who are suffering from sleep disordered breathing, especially obstructive sleep apnea. So obesity related complications, the incidence directly related to rising BMI. So it is very important to red flag these patients and look for patients who are having sleep disordered breathing. So how do we find out a patient who is having obstructive sleep apnea? Look at the persona of the patient. Patient with extreme obesity may be having very low self-esteem, maybe having very low energy. And sometimes in extreme conditions, they might be just sleeping and while giving their history, and their attendants might be giving history in their favor because they have come for rescue at at extreme stage. So everything needs to be noted. How did the patient come? Is the patient energetic enough to give the history himself, or it is one of the attendants who are giving the history? Do I need to subject this patient to a polysomnography or a sleep study? How do I predict the severity of OSA? So one thing is that we find out whether patient is already on a non-invasive ventilation or not. So we will be cautious in our history taking only and only if we are mindful of existence of these conditions. So it is not just about patients who are coming for bariatric surgery. It is also about other patients who are coming for non-bariatric surgery. So obese patient coming for non-bariatric surgery also, we need to maintain a very high index of suspicion and look for the presence of this condition. So there may be centers where sleep studies are not available. Now there are clinical parameters, clinical scoring system, the most popular of which is the stop bank scoring system, which has become very, very popular in last 1 decade. And it has been shown to be having very high correlation with the sleep studies. So we all need to be familiar with the how to score the stop bank scoring system. And for example, in our center, we have made the stop bank scoring system a part and parcel of the pre-anesthesia form so that no anesthesiologist ever misses out on filling up or evaluating the stop bank score of the patient. So the moment we do that, and not only that, we need to make a note of the neck circumference, the BMI, and in addition to other findings. So the stop bank score system has further evolved. So initially we used to say that if the score is more than 5, the patient is having a high chances of be suffering from obstructive sleep apnea. But now the score has been further modified. They say that even if a patient is having 2 or more of the stop part, it has 2 parts, the stop part and the bank part. So the patients who are having 2 or more of the stop part and any one of the bank, especially BMI and the neck circumference, then they should be considered to be having very high possibility of high score of severe sleep apnea. So these are the patients we need to be really aggressively work upon. So identify the patients and work on optimizing on the patients. The next important thing is the airway. So we must find out, is the airway difficult? How do we know that the airway is difficult? Now, in my previous lecture, we have already studied that there is distribution of fat, not only externally, but inside. They might be, in addition to that, enlarged tonsils, nasal obstruction, compromised hypopharynx, floppy epiglottis, enlarged tongue. So all that is compromising the upper airway. So definitely these are the patients who will be more prone to airway obstruction. So obesity will come with this. So we need to look for this.
So identify the patients who are having large neck, keep a measuring tape ready. If we are too busy a center, please familiarize the staff which is admitting the patient to the OPD to, measure the neck circumference in addition to the other demographics that we. Then our good old Malampati score or the extended Malampati score needs to be documented. It definitely continues to have a high relevance in assessing the difficult airway. So identify these patients. What about preoperative preparation? Now, preoperative preparations, of course, these patients look at the back of the patient. There might be a lot of fat deposited at the back of the patient. So these are the patients who would be having limited extension. If there is fat around the jaw, there will be limited maneuverability. There will be difficulty in application of a tight fitting mask, which means that they would be having a difficult mask ventilation. If they have an enlarged tongue, they would be having difficult laryngoscopy. They may be having difficulty in other airway maneuvers. So the pre-op preparation would be, we would be identifying these patients. Then the routine standard tests would be performed. Cardiorespiratory reserves we just saw needs to be done. Polysomnography is reserved only for selected patients. So there is a simpler test called as the nocturnal oximetry, which can be done as a domestic test or after the admission of the patient. It has importance even more than anything for documentation of the hypoxemic period of the patient. What is the minimum saturation that the patient achieves? So nocturnal oximetry is a much simpler test where the technician would come and put a probe and the patient can perform the normal activity and go off to sleep. So it has an SD card which is removed in the morning and it can be analyzed on the computer. So it tells us what was the minimum saturation that the patient achieved at night, how many times did the patient's saturation dipped, what is the oxygen diffusion index of the patient, for how long did the patient remain apneic. So these are the parameters that will help us in identifying the patients who need to be optimized, who need to be referred to a sleep specialist for initiating non-invasive ventilation in the form of a CPAP or BiPAP. So arterial blood gas analysis might be needed in some patient, and the patients who have pedal edema would also need a venous Doppler. Now, what's the worry in these patients? Now, these patients we have learned have extremely diminished oxygen reserves. They are very, very prone to hypoxemia. They're very sensitive to sedatives. They may be failure to extubate and even failure to ambulate. So we build up their respiratory reserves. We make a note of these, and we, in our typical pre-op instructions, we highlight we revisit the fact that no sedatives should be given to the patients. Patient would need, acid aspiration prophylaxis in form of proton pump inhibitors or H2 blockers, whatever are the favorites of the anesthesiologist. The antihypertensives need to be continued, thyroid medications need to be continued. If the patient is on any psychiatric medication, which invariably the patient is, we need to find out. And a lot of times we need to speak to the patient, in isolation. So in isolation, we find out whether the patient is suffering from depression, because if the patient is coming with multiple, attendants, and we subject them to these personal questions, it adds to the low self-esteem of the patient, and it adds to the misery of the patient. So some personal questions should be, patient should be subjected to these questions when the patient is alone, because patient may not be comfortable in disclosing. At the same time, we should take the patient into confidence, and we need to build up their confidence and give them confidence that patients, this thing would not be disclosed to the attendants, and that, these histories have major implications on the anesthetic outcome. So invariably, patients do disclose that they are on some sort of medications, which may be, medications for most commonly anxiety and depression, and sometimes even manic depressive psychosis. So thromboprophylaxis needs to be initiated. Patients are subjected to deep breathing exercises and nebulizations. The oral hypoglycemics need to be omitted. We need to make a careful note of supplements, hormonal supplements like oral contraceptive pills, which can actually worsen the prothrombotic state of the patient. We continue the incentive spirometry right into the preoperative period. The patients who are on NAV need to be, continue their not invasive ventilation till immediate preoperative period. If a patient is using any leg support or walkers, they need to be instructed to bring them along, because the patient would be subjected to early ambulation in the postoperative period. Patient needs to be familiarized with the post-anesthesia care unit and what the journey of the patient in the PACU is going to be like. Now, amongst the other challenges to the airway of the patient would be, measures to be taken right in the pre-op period to prevent desaturation. So breathing exercises will help in improving oxygenation. Patient is instructed to be sitting in a propped up position or taking, 2 to 3 pillows, so that it improves the lung volume of the patient and also helps in relieving obstruction, preventing the fall of tongue and opening up the airway. So head up position will definitely help in opening up the airway and in preventing the airway collapse to a large extent. So we know that, here is a picture depicting that, how the airways open up when the patient is in a lateral position and in the propped up position, and it even prevents the fall of the tongue. So we need to find out whether the patient has, any risk of aspiration. So are all obese fasted patients at a higher risk of regurgitation? No, it is not like that. So there are enough and more studies which have shown that an obese fasted patient will have the same risk of regurgitation and aspiration as a non-obese fasted patient. So not all obese patients will be at a risk of regurgitation. So these patients need to be identified, but there will be some patient who would be having hiatus hernia, who would give history of gastroesophageal reflux, who and diabetics might be having gastroparesis, or if a patient is coming for emergency surgery. So in these patients would definitely be, identified as having a possibility of aspiration. So now a lot of centers are using point of care ultrasound to identify, to find out, if the stomach is full and what is. So here is a picture depicting that, how an empty stomach looks like. So, we need to train as familiarize ourselves with the usage of ultrasound to find out, how to identify patients who might be at a greater risk. So only those patients, can be considered to be at a high risk of regurgitation. But what if a patient is having poorly defined landmarks? Even if we consider, rapid sequence intubation, it may not be possible to, occlude the patient's esophagus and prevent aspiration of the patient. So, in these patients, and these patients may even be having difficult front of neck access. So these patients require, expertise. They require the presence of expert and trained anesthesiologists, and at least 2 anesthesiologists needs to be present when we are inducing anesthesia in such patients. So these patients need to be identified right in the preoperative period. And some of these patients, we need to identify the cricothyroid membrane ultrasonographically and put a mark there, because the landmarks may not be visible. So these patients, so we need to be continuously upgrading our knowledge skills, and we need to continuously learn more and more and familiarize ourselves with point of care ultrasound and how technology can be used in making the anesthesia experience safer for our patients. So, if we subject these patients to rapid sequence intubation without putting a mark on the cricothyroid membrane, we know that we may get stuck with difficult mask ventilation if they have a large tongue. Laryngoscopy and tracheal intubation might be difficult. The patients will rapidly desaturate, and we, in fact, make the patient more prone to pulmonary aspiration. So we need to plan out anesthesia and airway management of these patients right into the preoperative period. So will I subject my patient to an awake intubation? Is awake intubation a cakewalk in these patients? No, it is not like that, because we need to know what is the best technique. If at all I'm planning awake intubation, we should not be considering nerve block for performing the fiber optic assisted intubation, because that will further collapse the already narrowed airway. So conscious sedation is the best possible technique if at all we are considering awake fiber optic intubation in these patients. So we must do all these preparations right into the immediate postoperative period. Then patients who are having limited jaw protrusion, like we do upper lip bite test, and if a patient is having limited mouth opening or a difficult neck extension, they are the patients who can be subjected to awake fiber optic intubation under conscious sedation, because these are the patients who we cannot possibly introduce a laryngoscope or be very sure that I will be able to perform mask ventilation. So mask ventilation is very, very vital in having a continuous oxygen delivery and continuing ventilation, and preventing the cannot ventilate, cannot oxygenate scenario. So these patients need to be identified right in the preoperative period. So another dreaded complication is the venous thromboembolism. So patients with chronic leg edema, so look at the leg of the patient, find out if there is pitting edema, find out if the patient is having varicosity. Are there signs of old healed ulcers? Is there stasis dermatitis and depigmentation? Because that is indicative of venous pooling. If there's depigmentation, that is suggestive of venous pooling. And then if a patient is a smoker, is giving history of previous venous thromboembolism, is polycythemic, has having thrombocytosis, or is having history of taking oral contraceptive pills. Now these are the patients who must be subjected to a venous Doppler study, and definitely we need to give them thromboprophylaxis. So pharmacological thromboprophylaxis in form of low molecular weight heparin, the TD stockings, and intraoperatively use of sequential compression devices need to be planned much in advance. Now, another dreaded complication is a rhabdomyolysis. So the patients who are expected to undergo prolonged surgery, if it's a complex surgery, if a patient is having extreme of BMI, male gender, extreme surgical positions, patients with ASA status, physical status 3 or 4, patients with diabetes or hypertension, definitely these are the patients who would be more prone to rhabdomyolysis. So we must be very, very careful in positioning these patients. And we must caution the surgeon right in the preoperative period that if the surgery is expected to last more than 4 hours, then maybe 2 hours or 3 hours, down the line, we need to neutralize the table position. We need to release the carboperitoneum so that, the circulation in the dependent part is resumed. And then after a gap, the surgeon can resume the surgery. So it is very important right in the preoperative period to have a rapport with the surgeon. Now, in the preoperative assessment, very important to note simple things like breath holding time, which give us a good indication of whether our preoperative assessment of diminished oxygen reserve is accurate or not. And if I have subjected my patient to deep breathing exercise, non-invasive ventilation, or incentive spirometry, and then we repeat the breath holding time, we will get a good indication that the breath holding time has improved. So making a note and noting down the date of when the breath holding time, and if I'm calling my patient after 2 weeks for reassessment, I will know that the patient has been following instructions and that there has been improvement in the oxygen reserves of the patient. Then make a note of the airway, revisit all the difficulties that we had highlighted. Make a note of the lazy lethargic patient, note down the pedal edema, look for signs of old head ulcers, depigmentation, stop bank scoring, and baseline SpO2. All these parameters are very, very important. Then important investigations and, should be noted. An X-ray can be giving a good idea of a restrictive lung disease, which we anyway, so pulmonary function tests may not be available everywhere. So we must, give stress to the basic simple tests that are readily available and know how to interpret them. Then make a note of difficult vascular access. If the veins are not visible, then we must need to plan right in the pre-op. We might need, a vein locator or help of an ultrasound to identify the vein. So in these patients, we will need to secure venous access even before we wheel the patient into the operation theater. So role of anesthesiologist as a perioperative physician cannot be undermined. So now I have assessed my patient already. I have identified the risk factors. I have optimized the patient, and now my patient is ready to be anesthetized. The day of surgery has arrived. Now, this patient in whom hypoxemia is the main concern. So, anesthesiologist who's riding on this horse is actually, tackling the most important and dreaded concomitant factor in the obese patient, that is hypoxemia, right from the pre-op assessment to induction, airway management, maintenance, emergent, post-operative pain, and even after discharge. Hypoxemia is going to be tackled at every point of time. Now let us move on to the next lecture and see how we can anesthetize this patient. And any questions related to pre-op assessment will be taken at the end of.
Thank you so much, Dr. Aparna Sinha. It was an excellent talk. I think preoperative preparation of patient is very important for any patient for that matter. But when it comes to patients with morbid obesity, I think it is extremely essential that we prepare the patients very well for a good post-operative outcome. You have very nicely highlighted how to evaluate such patients, what are the hidden issues which we must not miss out, and how to pre-operatively optimize these patients so that we can get the best of these patients in the post-operative period without any complications. The issues like nocturnal oximetry, which helps us to identify which are the patients who can have post-operative issues in the recovery period, and of course the pulmonary function as difficult venous access. So these which we have in anesthesia. Was for an excellent talk, and I now invite Dr. Parna Thakkar. She will be, after having laid a foundation with identifying the physiology and pathophysiological issues, and then of course preoperative optimization of these patients. We now move on to anesthesia consideration in patients with morbid obesity, and to speak on this topic is Dr. Parna Thakkar. Can I have the slide, please? Dr. Parna Thakkar is from Mumbai, a very well-known anesthesiologist there. She is a consultant anesthesiologist at Sir H.N. Reliance Foundation Hospital in Mumbai. Lots of degrees that she has with her, postdoctoral fellow in neuroanesthesia and research from US. She is also the treasurer of Indian Society of Anesthesiologists, Thane, Mumbai, and she's a reviewer for Indian Journal of Anesthesia. Her areas of interest include neuroanesthesia, liver transplant anesthesia, bariatric anesthesia, and liver analgesia. A very, very active and a vibrant person in not only in the Mumbai circles, she can be seen in various conferences all over the country. Dr. Parna Thakkar, the floor is yours. Please go ahead with your presentation.
Thank you, ma'am, for the kind words. It
You are
indeed
mute.
is a
Yeah, that's it.
pleasure to be on this platform. I thank all the organizers of ICA for giving me this opportunity. My special thanks to Dr. Aparna Sinha for not only giving me this opportunity, but also for guiding and training me in bariatric anesthesia. I'll be speaking on anesthesia for morbid obesity. Greetings from Sir H.N. Reliance Foundation Hospital, Mumbai. Wow. While anesthetizing these morbidly obese patients, we need a lot of planning and preparation. We need expertise, trained personnel in the OT, and also special equipment should be available in the OT before you start these cases. It's always preferable to have 2 trained anesthesiologists present in the OT while doing these cases. The special challenges faced while managing these morbidly obese patients are difficult venous access. Ultrasonography or vein finder can be used to place the IV line. Airway management, ventilation, hypoxemia, and desaturations are the main concerns at the time of induction. Possibility of the risk of aspiration has to be kept in mind. Positioning, monitoring, choice of anesthetic technique, and choice of anesthetic agents, fluid management, and pain control are the other concerns while inducing these patients. So to face these challenges better and to increase the patient safety, before wheeling in these morbidly obese patients, we need to prepare the OT adequately. A difficult intubation cart with bougies, stylets, and fast-track LMA should be kept ready. Oropharyngeal and nasopharyngeal airway of suitable sizes should be available in the OT. Video laryngoscopy has almost replaced fiber optic intubation while dealing with morbidly obese patients. It has become a gold standard technique for intubating obese patients. A video laryngoscope with D-blade should be available in the OT. However, fiber optic scope and front of the neck access equipments also have to be handy while doing these cases. Monitoring. In addition to routine monitoring like ECG, pulse oximetry, and IBP and ETCO2 monitoring, temperature monitoring is also very important in obese patients. NIBP cuffs of suitable sizes should be made available. ETCO2 monitoring is very important for confirming the endotracheal tube placement after intubation. Neuromuscular monitoring can also be done. This monitoring gives us a guide regarding the depth of anesthesia, urine output monitoring, invasive BP monitoring, CVP, and cardiac output monitoring can also be done in indicated cases. Induction. As we've seen in earlier lectures, that physiological changes occur in the respiratory system in obese patients. We need to be very careful while inducing these patients because they are very prone to hypoxia, especially at the time of intubation. So to prevent hypoxia, we need to position them adequately. Also, we need to pre-oxygenate them well. So how do we position them? So ramp position is given with 30 degrees head up, such that the ear and the sternal notch are in one line and the face is parallel to the ceiling. Ramp position is given either with towels, pillows, or bed sheets. Ready pillows like tube elevation pillow can also be used to position the patient. Pre-oxygenation. 100% oxygen is used to pre-oxygenate these patients. Monitor the end-tidal oxygen concentration and it should at least increase to 85% before the start of induction. Oxygenate them for 3 to 5 minutes. In case of emergency, 8 vital capacity breath technique can also be used. Ask the patients to take deep breaths intermittently. CPAP is also added while pre-oxygenating obese patients. 5 to 10 centimeters of CPAP is added. Oxygenation. We also need to start apneic oxygenation. So what do we do in that? So high flow of oxygen is given at high concentration, and this fills the dead space of the pharynx and larynx. Also, it fills the space in the alveoli. It increases the alveolar oxygen stores, and thus it delays or prevents desaturation at the time of induction. Apneic oxygenation also increases the safe apnea period. What is safe apnea period? It's the time between muscle paralysis and the drop in the saturation. In normal weight patients, the safe apnea period is 8 to 10 minutes. Whereas in morbidly obese patient, the safe apnea period is only 2 to 3 minutes. So by giving oxygenation and by simultaneously starting apneic oxygenation, we are increasing the safe apnea period, and this gives us adequate time to handle the difficult airway. Of apneic oxygenation available. Diffusion oxygenation with nasal cannula is the most popular technique used by most of the people as well as in our institution. Nasal cannula are used and 15 liters of oxygen is given through nasal prongs. High flow nasal cannula can also be used. Thrive can also be used at 30 to 70 liters of oxygen per minute. Buccal oxygenation can be done with RAE tube, which are fixed to the cheek. Induction agents. Short-acting drugs like fentanyl and propofol are preferred induction agents for morbidly obese patients. Succinylcholine or rocuronium is used for intubation. Also, it is useful for rapid sequence induction. Alpha-2 agonists like dexmedetomidine are also used in conjunction with other induction agents. It does not cause respiratory depression and it is therefore preferred in obese patients. Also, it reduces the requirement of the other anesthetic agents. For maintenance, atracurium and cis-atracurium is preferred. Drug dosing. Highly lipophilic drugs like propofol and succinylcholine are given as per the total body weight. Less lipophilic drugs like non-depolarizing muscle relaxants are given according to the adjusted body weight. We have to prevent the under and overdosing of the drugs. While dosing these patients, we need to keep the age and the physiological changes of the patient in mind. Desflurane and sevoflurane are the most suitable inhalational agents. Desflurane is the least fat soluble agent and it enhances the recovery and promotes rapid return of the airway reflexes, and that is why it is preferred in obese patients. Nitrous oxide is avoided as it causes intestinal inflammation and it is also emetogenic. Propofol and dexmedetomidine based total intravenous anesthesia, the TIVA technique, also has become very popular for maintenance and it is used by many anesthesiologists. Fluid replacement. There are two schools of thought for fluid replacement. One is liberal and the other is restrictive approach. In liberal fluid replacement, 40 ml per kg per hour of the total body weight of the crystalloids are given, whereas in restrictive approach, only 15 ml per kg per hour of the total body weight of the IV fluids are given. As per goal-directed therapy, fluids can be given according to the vital parameters and stroke volume variation and fluid responsiveness of the patient. Intraoperative ventilation strategies are aimed at minimizing barotrauma and volutrauma. Lung recruitment maneuvers are the maneuvers to open the collapsed areas of the lung and keep them open. Recruitment maneuvers, when combined with PEEP, leads to better oxygenation and higher compliance. 30 to 40 centimeter of positive pressure is given for 30 to 40 seconds, or 55 centimeter of positive pressure can be given for 10 seconds. So how do we give the recruitment maneuver? So the APL valve is adjusted to 30 centimeters of water and the positive pressure is given for 30 seconds. Also, some of the newer anesthesia workstations have a procedure mode where the vital capacity and the hold time can be adjusted and recruitment maneuver can be given. Tidal volume. Tidal volume is given as 6 to 8 ml per kg of the projected body weight. PEEP of 6 to 15 centimeters of water is titrated to oxygenation. Plateau pressure should not exceed 30 centimeters of water. Respiratory rate is adjusted to maintain the EtCO2 between 30 to 40 millimeters of water. FiO2 of 40 to 80% is acceptable. Positioning. Positioning is very, very important in these morbidly obese patients. We need to spend adequate time while positioning and strapping the patient before the start of the surgery. So adequate strapping is done so that the patient does not slip while the procedure is on. The pressure points are padded well with jelly pads or with pillow so that nerve injury doesn't occur. Also, rhabdomyolysis is not a concern in the post-op period. DVT stockings are very important to prevent deep vein thrombosis in the post-op period. Pain management. Multimodal analgesia is practiced to decrease the consumption of opioids. Drugs like paracetamol, NSAIDs, acetaminophen, and dexmedetomidine can be combined with local infiltration and nerve blocks. TAB blocks are very popular in bariatric and abdominal surgeries. IV PCA with fentanyl can also be used for post-op pain management, but we need to be very careful while using IV PCAs in morbidly obese patients. Extubation criteria. At extubation, the patient should be fully awake and alert. He should be able to hold the head for more than 5 seconds. He should be hemodynamically stable and normothermic, which is very important. Patient should be adequately reversed. The respiratory rate should be less than 30 per minute. SpO2 should be more than 95% at FiO2 of 0.4%. Tidal volume should be more than 5 ml per kg and the patient should be relatively pain-free. At extubation, these patients can rapidly desaturate. Supplemental oxygen alone may not be sufficient to maintain the oxygenation. If the patients were on CPAP before the surgery, they might need CPAP in the post-op period. But some of the patients who were not on CPAP before the surgery may also need CPAP in the post-op period to maintain oxygenation. These patients should be observed in the high dependency unit after extubation. Regional anesthesia again could be extremely challenging in these morbidly obese patients. There could be difficulty in positioning them. There could be difficulty in identifying the bony landmarks, the midline, and there could be difficulty in palpating the spinous processes. Sitting position is preferred compared to the lateral position. They require longer spinal and epidural needle. There are increased chances of bed tap during epidural placement. Ultrasonography can be used to place the blocks. Obese patients need lesser local anesthetic drug compared to normal patients. Around 20 to 25% of the less of the local anesthetics are needed in obese patients. With this, I end my lecture. Thank you very much for a patient listening.
Thank you so much, Dr. Parna, for your excellent coverage of the lecture. So with that, we will move on to yet another important aspect of anesthetic management, that is pain management. And to tell us more about it, I will like to invite Dr. Anu Vijayant Goel. Dr. Anu Vijayant Goel is Additional Director at Fortis Hospital, Shalimar Bagh. He is one anesthesiologist who is extremely hardworking and diligent. I have yet to see people who are more diligent than Anu. So Anu is a very hardworking and anesthesiologist with interest in varied fields of anesthesia, specifically labor analgesia, anesthesia for joint replacement, renal transplant, and not to say the least, the anesthesia for bariatric surgery. So Dr. Anu, please.
Very good evening. I am very obliged to be the part of the panel, which is consist of my teacher, Dr. Aparna. She taught me a lot about management of morbid obese patient. My experience of fellowship was excellent. Whatever I know about obesity and its treatment is what she taught me. I will try to replicate that. I would like to share. I was 110 kg when I did my fellowship under Dr. Aparna. So I can experience what a obese patient or a obese person can experience. So I will be talking mainly about the pain relief in morbidly obese patients. This is my designation. I am working as additional director in Department of Anesthesiology, Fortis Hospital, Shalimar Bagh. Morbid obesity causes a challenge for perioperative pain management. Opiates have limited role due to safety concerns in patient with or without OSA. Don't think if OSA is not there, opiates are safe. In obese patients, opiates have really safety concerns, and we should keep that in mind. We also need pain relief. What a obese person, leave about patients, what a obese person thinks. बाजार जाता है उसको कपड़े नहीं मिलते, शादी करने जाता है लड़की नहीं मिलती, at least उसको pain relief तो अच्छा मिलना चाहिए, which we can provide. हम अपने डर की वजह से उसको we keep him or her devoid of pain because we fear of the complications which can be the obese patient. But that is not the case. We should be very concerned about their pain and their demand, and we should utilize all the modalities available to make them pain relief like any other patients. There is a spite also because of advanced technologies. More surgeries are done during these days are done laparoscopically, which decreases the analgesia requirement, and there is very fast recovery in post-operative period. Still, the post-operative pain still remains the main prime factor of patient dissatisfaction towards surgical experience. Operation सब कुछ अच्छा हो गया डॉक्टर साहब, लेकिन patient जब गया तो pain लेकर गया. All the hard work done by the surgeon, anesthetist in preoperative period is gone in vain just because we could not provide him a good pain relief. तभी कहते हैं closing chapter अच्छा होना चाहिए. Patient should go satisfied, go home with good pain relief. Only a satisfied patient can send more patients to the hospital or the surgery. There is morbid obesity associated with unique physiological alteration that modify both pharmacokinetic and pharmacodynamics of opioids, resulting in increased sensitivity towards unwanted side effects, respiratory depression like oversedation, nausea, and vomiting. As I told in earlier slide, because of this side effects, not because of these side effects, because of fear of these side effects and fear of complications, we undertreat pain. There are also unwanted complications like hypoxemia, atelectasis, pneumonia, because patient is not able to breathe deeply due to pain. When there is pain on breathing, patient will hold the breath, and it will result in all type of complications. So, good pain relief is very important for the recovery of these patients and to decrease the complication rate in this patient in post-operative period. What is the answer? Very simple. It should be a multimodal analgesia technique. Components can be modulation pain afferent to the brain, elevating central perception of pain, enhancing pain inhibitory pathways. Non-opioid systemic analgesics can be divided into primary analgesics, which consist of NSAIDs and paracetamol. Systemic adjuvants, which contains ketamine, dexmedetomidine, pregabalin. Yes, why IV is better to IM? There is no rocket science in this because of increased layer of fat in the patient. हमने तो IM लगा दिया, but all the drug is deposited in subcutaneous fat because needle muscle तक पहुंची ही नहीं है. So there will be inconsistent drug absorption. There will not be results which we want, and patient will be dissatisfied. So always use IV infusions or IV shot in morbidly obese patient rather than IM injections. In anesthetics, there is, all we know, there is inhibition of cyclooxygenase. Yes, they are good for mild to moderate pain. Maybe they are not that good for severe pain, but they are fairly safe with minimal platelet dysfunction and renal and GI side effects. Very important thing I would like to stress, they should be used round the clock instead of as needed. We should not wait, patient will demand. It should be time-based. For example, if you are using paracetamol 1 gram 6 hourly, by clock it should be repeated after every 6 hours. Should never wait for patient asking for pain relief. This is the main crux of this pain relief. That's why it is said it should be time-based rather than analgesic demand-based. Paracetamol is devoid of renal, hematological and GI effects because it has central mechanism of action. It has been proven in many studies in morbidly obese patients, use of paracetamol with low dose of narcotics allows patient to be managed in SDU rather than CCU. Coming to ketamine, very old drug, but gaining more and more popularity. Again, these days it has increased in ICUs also, in postoperative pain relief also. In small doses of 0.2 milligram per kg, it is an analgesic. It has anti-hypergesic effect and prevents opioid-induced tolerance. As we all know, there is no suppression of respiratory drive or airway tone. Post-operative infusion dose of up to 0.2 microgram per kg per minute is very well tolerated with minimal cognitive impairment and hallucinations. Solenzi et al. Demonstrated that pre-induction ketamine infusion in patients with morbid obesity undergoing biliopancreatic diversion was associated with early extubation and diminished post-operative analgesic requirements. When we used to use ketamine, we stopped using ketamine because in post-operative period, patient was very noisy, many hallucinations. उसको तो कुछ होता नहीं होता था, हमारे 3 पेशेंट पोस्ट ऑपरेटिव से भाग जाते थे, डॉक्टर साहब ये क्या दवाई दे दी आपने. But now in a new version, it has been so seen because small doses does not cause this type of side effects and patient is very, very comfortable in post-operative. So we should always consider use of ketamine. Very upcoming drug. I will not name it new because I'm using it. I think those for last 12 to 14 years I'm using this drug, and I am fan of these drugs. It has selectively for alpha-2A receptors that have roles in analgesia and sedation. Very unlike clonidine, it has more selectivity for analgesic oblique sedative action with less hemodynamic adverse effects. Intraoperative infusion reduces both intra and post-operative opioid requirements with very, very stable hemodynamics. Low in doses less than 0.4 microgram per kg per minute, it causes minimal hemodynamic and respiratory compromise. This drug is now the very important part of anesthesia study because it solves so many problems of anesthetics. Not only in operation theater, when we want to sedate any obese patient in endoscopies, for MRIs and any other peripheral procedures, I always prefer using dexmedetomidine, and I am very much satisfied with the results of dexmedetomidine. Preoperative pregabalin we have used extensively. Single dose in a preoperative period decreases post-operative analgesic requirement, and that may extend up to first post-operative day. Other adjuvants are also used under trial with various outcomes like lidocaine infusions, clonidine, magnesium. They are used in many studies. They have their own effects and side effects. Very important component of multimodal anesthesia is regional anesthesia. There is no multimodal anesthesia complete without mentioning about regional anesthesia. It's a component of multimodal anesthesia, as I said, because it avoids risk of obstructive sleep apnea, difficult airway, and many other pulmonary complications associated with general anesthesia. They causes better pain relief, and they cause early discharge from the hospital. It can be regional anesthesia techniques can be used for both surgical anesthesia and post-operative pain relief. It can be divided into central neuroaxial blocks and peripheral nerve blocks. A word about central neuroaxial blocks. Yes, I know, technically very difficult as landmarks are obscured because of subcutaneous fat. Sitting with best possible flexion at spine is a critical for success of procedure. I would like to stress, rather than any position, good support, good technician who is well known about this position. I always call my best technician if I am going to give regional anesthesia to obese patients. So environment should be friendly. There should not be any reason these difficulties cannot become. We can always achieve the regional anesthesia techniques in morbid obese patients. Yes, intrathecal opiate should be avoided. We can use adjuvants like clonidine, dexmedetomidine, magnesium, dexamethasone for prolonged analgesic effects. In most of the cases, I'm using dexmedetomidine routinely, frequently, and excellent results. Up to 6 to 7 hours of analgesia is there. Continuous epidural technique using local anesthetic have shown favorable results in terms of respiratory function and return of bowel function. Peripheral nerve blocks, it is said it is associated with higher block failure and complications, but this doesn't mean we should exclude these patients for regional anesthesia. Patients with obesity have more fat in lower limbs. Thus, lower limb blocks may be technically more challenging with landmark techniques, and one may have to resort to neuroaxial block. Yeah, this is the most wonderful thing happened to anesthesia in last decade. Ultrasound in operation theater and with anesthetists have resolved so many problems, If I talk about the peripheral nerve blocks and regional anesthesia, there is very high success rate with very low complication. But for obese patient, we need a low frequency probe for visualizing deeper tissue. But if I talk about these days, there is no anesthetist. There is no anesthetist who is complete without a training of ultrasound in each and every field, starting from central venous access to blocks. So ultrasound is a revolution, and better revolution. Dr. Aparna she's here, and she taught me about this block when I was doing my fellowship. Transverse abdominis plane block along with rectus shield block. And till date, it is my favorite block. There is no laparoscopic surgery in my OT in which this block is not given. There is no caesar in my OT in which this block is not given. Very excellent pain relief, I would like to mention about IPOM surgery. In IPOM surgery, we put so many tackers, and in post-operative period, patient is very tense and full of pain, very tense abdomen. Doctor saab, pain relief nahi hai bilkul bhi. And the day I started giving tab block before putting the mesh in my IPOM patients, patient is excellent. Nowadays the things are like that. मैं याद दिलाऊं ना दिलाऊं, मेरा surgeon मेरे से पहले बोलता है boss वो tab block लगाना है, because they see the patient in post-operative period and there is more difference and outcome of this block. So I said this is my favorite block and I never missed putting this block. And with the help of ultrasound, it is very easy to give and very effective. Preemptive anesthesia is always has better outcomes. It also lowers the incidence of conversion of acute pain to chronic pain. Yes, everyone want to drive his or her own car. कोई ड्राइवर के साथ बैठना पसंद नहीं करता, क्यों? Everyone likes कि उसकी लाइफ का कंट्रोल, उसकी गाड़ी का कंट्रोल, उसके घर का कंट्रोल उसके हाथ में हो. Like for wives, वो चाहती है उसके हस्बैंड का कंट्रोल उसके हाथ में हो. Otherwise, pain control should be in the hand of a patient. Results in very good results, very good pain relief, and patient is very, very satisfied. Other techniques also, long-acting local anesthetic at surgical wound site or intraoperative infusions. Just to conclude, yes, to use of multimodal approach for analgesia can serve as remedy for both opioid underdosing or overdosing, thus improving patient satisfaction, towards surgery in patient with morbid obesity. And our target is happy patient going home with good pain relief and very good experience out of the hospital. Thank you very much. This is my department. Thank you.
Thank you so much, Dr. Anu. It was excellent coverage. It shows your training from an excellent teacher. As a teacher, so the student who is just following her footsteps. And I'm sure you will prove an asset to your department as well. You have highlighted the role of multimodal anesthesia for these patients, and also the role of ultrasound, which helps you to perform various nerve blocks and avoid the narcotics and other things that you might need to give just in case you don't perform the blocks. Thank you so much for once again for your excellent presentation. And now, having gone through anesthesia and of course pain relief as well, we come back to the post-operative outcome. And for this, I have the privilege to invite Dr. Aparna Sinha once again. Dr. Aparna Sinha, please go ahead with your talk.
Thank you, sir.
So let us move on to the next very important part of anesthesia care. So post-anesthesia care is a very, very important part of anesthesia, because we have to understand as trainees, especially, that anesthesia does not end at extubation. The post-operative period, especially in morbidly obese patients, is very, very important period. Now let us see how. So patient has been extubated and patient is in the post-operative period. So post-operative pain and even home care are very, very important. Now let us see what the literature says. Now, if you look at the literature, there are many studies, and this is one of the most landmark studies, where they have found out that the sleep disordered breathing, especially obstructive sleep apnea, has very high correlation with the post-operative complications. So we must be aware and very, very cautious about these patients who have, in morbidly obese patients, obstructive sleep apnea is almost part and parcel of the disease process. So almost every patient should be considered to be suffering from obstructive sleep apnea unless proved otherwise. So all these patients, we have to be very, very cautious. So be it the respiratory complications, be it the cardiovascular events, GI events, and even post-op bleeding has been shown to be very common in patients with sleep disordered breathing. So what are the considerations at emergence? The primary aim is that we wash off the inhaled anesthetic, but not build up the carbon dioxide. Pressure support ventilation to maintain the FRC should be continued. Prophylactic nasal airway is very, very handy. Nasal ventilation has been considered to be superior to oral ventilation, which has been shown to be shown in many studies. So a lot of our patients would be on non-invasive ventilation. So if they are finding it difficult to comply with non-invasive ventilation using an oral mask, we must familiarize them with the nasal mask right in the pre-operative period. So nasal ventilation can be continued, and the patient's position, we have already learned, is very, very important. So patient should be in the semi-upright position. So does anesthesia and analgesia influence the pathophysiology of OSA? It certainly does. So sedative, hypnotics, opioids, and muscle relaxants reduce the upper airway tone. They reduce the ventilatory response to hypoxia and hypercarbia, and worsen or induce the obstructive sleep apnea. So we have just learned that how post-operative pain management is extremely important in managing the anesthesia for a patient with morbid obesity, and it will have an extended effect into the post-operative period. So we learned just now that multimodal analgesia and involving regional techniques like loco-regional blocks like tap block or subcostal block, or even wound infiltration, and depending on the surgery, including regional anesthesia as a part of general anesthesia technique, will help us in obviating the need for opioids into the postoperative period. Why? Because the opioids may have severe adverse effects, and now we are in an era where enhanced recovery after surgery. So obese patients, even obese patients, can be subjected to enhanced recovery after surgery. So the postoperative period should use minimum of sedatives and opioids. So we have to follow what is called as opioid restricted or opioid free anesthesia as much as possible. So drugs that inhibit arousal response and protect against asphyxia leading to life-threatening apnea should definitely be avoided. Now, for knowing the safety of these patients in the postoperative period, we must know what are the postoperative sleep patterns in a patient with obstructive sleep apnea. Now, under the surgical stress, anxiety, and pain leads to disturbed sleep architecture in the postoperative period. This leads to reduced total sleep time and sleep deprivation and sleep fragmentation in the first postoperative day. And this further leads to suppression of the REM sleep. Now, rebound because of suppression of the REM sleep in the first day or two, it has been seen that in the third to fifth post-op day, which means that, in a lot of surgeries, patient is discharged on the third day. Then it has been seen if the patient has not been instructed to continue the non-invasive support when even after discharge. So we have to tell the patients the attendants who are accompanying the patient that they have to ensure that while the patient is asleep, they must continue the non-invasive support, because there is a rebound increase in the density and duration of REM sleep in the third to fifth day, leading to nocturnal respiratory depression, and there is increased airway obstruction, and even life-threatening apnea can happen, leading to increased hypoxemic episodes, increased sympathetic output, and increased cardiac events in the postoperative period, which may happen even after discharge. So it is very important to familiarize the patient with these outcomes and be very, very mindful of these adverse outcomes that may happen if we are not cautious enough. So the pain behavior in the sleep apneic patient. Now, sleep apneic patients will have two types of phenotypes. Those who have sleep fragmentation or sleep deprivation, and those who have recurrent nocturnal hypoxemia. Now, the patients with sleep fragmentation promotes inflammation and leads to spontaneous pain. So these are the patients who will have enhanced pain sensitivity and will have hyperalgesia and increased pain perception. Whereas the patients who have nocturnal recurrent hypoxemia will have increased opioid potency and reduced opioid requirement. So we need to very carefully observe these patients and to identify these patients right from the preoperative period. So once the patient has been extubated and is in the postoperative period, we need to observe the patient carefully and be very, very cautious about administration of opioids. So this is one of the few reasons why opioids will be harmful in both. Opioids will be detrimental in both groups of patients. So this is the reason why these patients need to be having opioid restricted or opioid free analgesia. So infusions like dexmedetomidine, nerve blocks, they are very, very valuable in post-operative period in these patients. So what are the other things that we need to be mindful about in the post-operative period? Now, let me show you a case report that was published in a surgical journal sometime back. Here they showed that during the nursing check in the post-operative period, a nurse found a patient who had undergone surgery the previous day to be 49%. So she initiated oxygen in this patient, She was a good nurse. She observed, she watched for some time. She saw that the oxygen improved to more than 95%. So after that, she resumed her duty. A few hours later, the patient's attendants came crying to the nurse that patient is not responding. The doctor was informed and they found that the patient was dead. So why did this dead in bed situation arise? The dead in bed situation arose because these patients, we discussed in the preoperative period that we need to make note of the baseline SpO2. So the oxygen administration only has to be to bring the oxygen levels to the baseline SpO2. We cannot keep continuing hyperoxygenating the patient without finding out what the CO2 levels are. So it is very, very important for the anesthesiologist to keep the patient in an environment where the CO2 also can be monitored. So in the immediate postoperative period, we cannot shift a patient to the room till the crisis is over. And the CO2 monitors are being really emphasized in the recent times and have been found to be indispensable monitors in the postoperative period. So it is very important to train the nursing staff also that what is the point of time when they need to call for the doctor. So they cannot be allowed to administer oxygen without informing the anesthesiologist on duty. So they need, these monitors like capnostream are very, very useful. And so what should have been done in this patient is that patient should have been initiated on a low dose of oxygen to bring the oxygen up to the baseline, and then initiated on the non-invasive support. The use of supplemental oxygen in the post-anesthesia care unit, patients on NIV should continue post-op NIV. Treat recurrent hypoxemia and NIV rather than increasing the FiO2. Use supplement oxygen with caution and do not hyperoxygenate these patients because we need to give them permissive hypercapnia, and we cannot take away the respiratory drive which is coming from the CO2 of the patient and from the baseline hypoxemia that can be considered acceptable in monitored environment. So supplemental oxygen versus positive airway pressure, we need to familiarize our nursing staff and the trainees about how to take care of these patients in the postoperative period. So postoperative outcomes are actually an interplay of severity of OSA and obesity, invasiveness of the surgery, how long the surgery was, what is the compliance of the patient to the non-invasive ventilation, what was the timing of NIV, any requirement of opioids, and how well the patient has been optimized. Screening tools are very, very handy. So we should strategize the post-operative plan. So post-operative care plan should be strategized right in the preoperative period. So while we accept a patient for general anesthesia, we must ensure that the post-op area has the availability of a non-invasive ventilatory device. Then the availability of opioid antagonists like naloxone should also be ensured. We must train the post-operative care providers for how to use the NIV, how to interpret the EtCO2 monitor, and when to oxygenate and how not to hyperoxygenate. And more than anything, documentation of all the events is very, very important. So the peri-op concerns in patient with morbid obesity and OSA are technical difficulties like venous access, regional blocks, monitoring, difficult tracheal intubation, regurgitation, pulmonary aspiration, airway obstruction, respiratory depression, cardiovascular complications, renal dysfunction, rhabdomyolysis, deep venous thrombosis, and embolism. Perioperative risk reduction strategy. In general anesthesia, limit the opioid dose, perform recruitment maneuvers whenever possible, Incorporate multimodal analgesia and regional anesthesia whenever possible. Look for opioid-induced respiratory depression. Do not hyperoxygenate. Continue NIV till the return of normal sleep patterns. And what are the recommendations? Maintain a high index of suspicion, educate and interact with the surgeon. Use clinical scoring system. Preoperative optimization goes a long way in enhancing the recovery of the patient. Educate the patient and the family also. So with that, we come to an end of this session. We are now open for any question and answer sessions. And we will very soon be coming back with season 2 of our bariatric anesthesia CME, where we will discuss the AV management and management of a sleep apnea patient in detail. So we are now open to question and answers.
Thank you so much, Dr. Aparna Sinha, for an excellent talk to end it up so beautifully after very nice presentations that preceded your presentation. Well, as Dr. Sinha has said, the house is now open for queries, questions that you have.
So I have seen a few questions that have been answered in the chat. So I will sort of begin with some questions, which we haven't answered. So Dr. Siva wants to know, does morbid obesity classify under ASA grading? Yes, very much. Morbid obesity is classified under ASA grading, as all morbid obese patients are ASA 3 and above. So if we consider the WHO definition, then extreme obesity is BMI of 40 and above. Whereas for Asian population, there are MOSI guidelines which have redefined the definition of morbid obesity for the Asia Pacific. So there, if the BMI is 37.5 and above, or if it is 32.5 with comorbidities, then it is considered as morbid obesity, and all morbid obese patients are ASA 3 and above. So that is one question. The another question from Dr. Siva is about CPAP. Is CPAP contraindicated in patients with hiatus hernia? No, CPAP is not contraindicated in patients with hiatus hernia, because we have been using CPAP very frequently in these patients, and even in patients who undergo surgery for hiatus hernia. And a lot of morbid obese patients who undergo, other surgeries and do require non-invasive ventilation in the perioperative period, they do require, we have seen that in these patients, there is no gastric aspiration. Essentially, NIV is driven by patients' negative pressure also. So unlikely that, stomach inflation is there. So definitely in patients are trained in the pre-op as to how they coordinate with the flow that comes from the CPAP machines, the BiPAP machines, and patients who have been, sort of educated in the preoperative period, they do well. And we don't see any, gastric insufflation with use of NIV machines. So maybe that is more of a myth. And we use it very, very frequently. And another fear that some surgeons, these questions have come to us in some conferences, is that they fear that maybe the anastomosis may give way if to an obese patient we attach the NIV. So we have not seen that happen in any patient, and we really don't believe that that can cause any gastric insufflation. So I hope that answers a question of Dr. Siva. And some questions are for Dr. Parna Thakkar, which she has already answered, but I would request her to, sort of talk about it again, about dosing of neostigmine in patients with morbid obesity and propofol in patients with morbid obesity.
See, actually, all the doses are according to the adjusted body weight. So when the actual body weight is more than 30% of the calculated ideal body weight, we calculate the doses according to the adjusted body weight. So all the drugs are given according to adjusted body weight, except succinylcholine, which is given as total body weight. And that holds true even for neostigmine. But little variation here and there occurs depending on the age of the patient, and how long time back have you given fentanyl, and how long time have you waited after giving fentanyl and started propofol. So little variation occurs here and there, but all the drugs are given as per adjusted body weight.
I don't see any other question coming up. So one thing I would, if Dr. Baljit would allow me.
Please.
Yeah, some points that I would just want to re-emphasize and sort of sum up what we learned. So when we are choosing an anesthetic technique and when we are choosing a pain management technique, our focus is to have enhanced recovery after surgery. So enhanced recovery after surgery is very much applicable to obese patients and more so with patients with morbid obesity. And so choosing the medications, as Dr. Thakkar has just highlighted, is, that we choose medications with rapid emergence. And when and short-acting agents, all the modern anesthetics are fitting into that category. And when we are familiarizing a patient with how the post-op care is going to be like, as I highlighted that, patient is encouraged to bring their walkers, they bring their sticks to the hospital, and we tell them that we will make you walk, and this is how the post-op area looks like. And a lot of enthusiastic consultants, they keep pictures of their post-op in their mobile, and they show them, that this is how incentive spirometry is done. This is how the post-op unit is going to be like. And look, this patient is walking, so you will also be able to walk. So all these points of encouragement definitely boost up the patient, and they definitely look forward to walking in the post-op. So that not only allays the fear of the peri-op physicians about the thromboembolism and venous stasis, because the moment the patient starts walking, even if the patient is using a walker or a stick, we are happy that, even if on the day one, we are not giving any pharmacological agent for thromboprophylaxis, patient is safe. And then, encouraging the patients to start walking as early as possible definitely goes a long way in enhancing patient safety. Avoiding urinary catheter, and the washroom is at the other end of the recovery. So patient wants to pass urine, we encourage them to walk. It becomes like an incentive to walk, that they want to walk till the washroom to avoid their bladder, and they get into that habit. It gives them confidence. So training the post-operative nurses, the ward boys, and the general duty assistants who are available is also very important, a part of anesthesia care of these patients. So would you like to add some comment?
No, I think you have summed it up beautifully. I think apart from just the last sentence that you spoke, it gives them confidence, quite right. No denying that. But apart from the confidence, see, when they are mobilizing, the possibility of, venous thrombosis also goes down considerably. So apart, that they can move around, they feel good. They have psychological boost. So they also reduce the possibility of venous thromboembolism. So that's another positive thing that happens when the patient is made to walk. I don't see any more questions
Yes, sir.
at in the chat box or in the question answer box.
I think we have covered all the questions.
Dr. Baljit,
yeah.
Sir,
could I put up a question?
please do, sir.
Yeah, Dr. Aparna, you
Yes,
are
sir.
telling about the physical deconditioning. How
Yes,
long
sir.
you practice the physical deconditioning? And do you mean that you are going to bring the patient from ASA3 or ASA4 to, well, ASA2 or something like that?
No, it is.
How many weeks of deconditioning you may need?
Yes, so deconditioning, so it varies from patient to patient. Patients who are absolutely immobile or are having super obesity. By that, I mean, if the BMI is 50 or more, and patient is having lab parameters which are showing liver involvement, there is already derangement of liver enzymes, there is onset of CLD-like picture in form of non-alcoholic steatohepatitis. So these are the patients who we really feel will benefit if, so in the period of physical deconditioning, one, they are subjected to physical activity, deep breathing exercises, and we encourage them to start walking. In addition to that, we are also measuring, we're doing body composition analysis, which gives us an idea about how much is the extracellular water. So if there is pedal edema, that definitely gives an indication, but pedal edema, as for example, could be other reasons like venous compression or, a thrombus sitting there or varicosity. So these patients, we subject them to body composition analysis. We get an idea about how much water content is there. So we add some diuretics as well in these patients. And if there is liver involvement, they are also put on low calorie diet. So when the patient comes after 2 weeks, we reassess the patient. So these are the patients who are reassessed to see if they're actually compliant, if they're following the orders, if they are doing